Hello, viewers. This is the Prosthodontics on Friday to look at various implant issues and also solve various side effects. This is our first session of 2022, and today we are going to talk about things to consider for full mouth rehabilitation, and our speaker today is Professor Park Chan-jing of Gangneung Wonju National University. It's been already 2 years where we talked about screw loosening of the implant abutment. Thank you for joining us again. So could you give maybe summary of today's lecture? First of all, I'd like to thank OSSTEM for giving me this opportunity, and above all, I'm really honored to be here together with my mentor, Professor Jo In-hoo, today. So today, what I'm going to talk about is when it's not about like doing one plan because of wear or abrasion. It's more about full mouth rehabilitation. So for that case, what you need to take into consideration, because it's a full mouth and not just a single or two implant placement. Yes, thank you. So for full mouth rehabilitation, what are things to be considered? I look forward to your lecture. Now, on Deno's site, if you are joining us, please on the right of your screen, you will see the chat box. So please post your questions there. And if we answer your questions, we'll give you Starbucks coffee coupon. We look forward to your participation. And with that, we will start with Professor Park's lecture. Hello, as introduced, I'm Park Chan-jing from Gangneung Wonju National University. As was introduced, I'm going to talk about things to consider for implant restoration in case of full mouth rehabilitation because of teeth wear and abrasion. So this is one case. It's an old case, and you can see the occlusal plane there's a waves, and there's a fixtures used, not much of functions, and you see a lot of fractures and wears. So this is a case where you need a full mouth rehabilitation. So this is after rehabilitation. It's been a while. So in terms of aesthetics and materials, so there are things from today's view lacking. And you see, in case of the full mouth rehabilitation, we use implant. You need to have a long-term view. There's a lot of changes and prosthetic materials that could have perio issues or material-related issues. So you have to take a lot of care. So from this to this, basically, what are the basic concepts and approaches that you need to think about? That's what I want to share with you today. So this is from textbook. If you do fixed restoration, in terms of treatment strategy, this is something you know. Establishment of horizontal and vertical relationship is important. You also need stable occlusal stop, and you need to have a harmonious anterior guidance, and restoration of collapsed occlusion and masticatory function needs to be comfortable to the patient. So this is something you already know. In terms of how you do rehabilitation, are you going to use fixed or removable? So using implants for full amount, you could do, fixed or removable, but prognosis will be different, and also cost-wise. Everybody knows fixed is more efficacious, but if you inevitably have to opt for removable, what's written here is something that becomes challenging. So using implant, simply put, it can be overcome. But removal is not something I'm going to talk about today, so I'll skip that. So these are the 5 things you need to be mindful. What is most important is that overall stable stop is needed. What I always emphasize is the MI position. So the stable stop on all teeth when condyles are in centric relations is very important. So stable stop is not at the same timing on the both sides. It needs to go on the with the MI, and you also need a lot of harmony in disclusion, and that there should be no interference. Now, this is treatment procedure, and this is sort of showing the flow, overall flow. So there are basically 3 steps: diagnostic step, treatment phase, and then the maintenance phase. And for each phase, you need a lot of knowledge. So that's what I'm going to focus on today. So this will be all kind of the summary slide for today. So from the diagnostic phase, these are the things to be considered, and the treatment phase, VDCR provisionalization is needed. In the maintenance phase, occlusal stability and other things are needed. And through this, you need to increase longevity, and you also need to be very thorough in doing this and achieve patients' compliance. So conceptually, it's very kind of given things. These are the 4 things I think is very important. So let's start with the first one. I think the most important thing in the anterior or full mouth rehabilitation is, although it says full mouth, mostly cases there are teeth that need to be removed or teeth that are missing, and that's why you need a lot of posterior support. This is a key concept. So this is one case. So overall, they are teeth, but because of perio problem, you have to extract, and there are 4 remaining on the upper side and few on the lower side. So you see vertical dimension, but it's still maintained. So rehabilitation kind of becomes easier. So what needs to be considered is that even removable, you can create as powerful as fixed ones, and with the fixed bridge on with the use of few implants, you can easily solve a lot of challenges here. So although it's, yes, full mouth rehabilitation, but the easiest and simplest rehabilitation. So it's use removable and fixed are both used, but for patient, it's closer to kind of like using removable. So it's an easy case. So posterior support. Now you have like this categories, and this is called Eichner index. I don't know whether I'm pronouncing this correct, but this kind of the posterior support index he created. So you have the occlusal contact end zones, and you have the 1 pairs of the upper and lower side of the premolars, and the molars also pairs on both sides. So 2 premolars and 2 molars, if you have that zones, pairs are opposing, and in total 4 is more favorable for any type of restoration. So using implant, category B is created into category A, that is the making things simple. So category B, occlusal support zone is 1, 2, 3, and you also have category C. So these are the overall index that you could use. So from category B, using the implants, posterior support, if you can have in 4 zones, then you can have restoration that is in the category A. That is how you can interpret this index. So if you do that, the key thing is in the rehabilitation content, laying good foundation is important. So premolar in the molar zone, one pair posterior support on both sides needs to be there and needs to be maintained, or the condition like that needs to be created using implant. That is very important. Second concept is occlusal plane. So this is something you probably also learned in school. And if you see this patient, now on the MI status, the vertical and horizontal status, vertically there is a lot of collapse, and you cannot really tell where the occlusal plane needs to be done because there is a protrusion and there is a lot of imbalance. So textbook approach, I believe here is important. So you know all this, so I'll just go very quickly. So Elytragus line and Kemper's line is the standard. Another reference is parotid papilla. There should be a certain distance from the occlusal plane. And for hamellar notch incisive papillar plane, this is hamellar notch on both sides, and this kind of inclination from the center. So this how the teeth has remained, and teeth are inclined or distorted, and by having a stable landmark that will not change that much, you can set it as a reference. And what is important is that you have to look at different standards, not follow one indice or standards, but look at different things. So you do assessment on the orally, and you create models to evaluate. And also on the tongue, when tongue is resting, you see the height being occlusal, similar to occlusal plane, again from the textbook, and also commercial of lips is something you also reference a lot. And also buccinator groove, if there's a clench, then on the buccal inside, buccinator groove do exist. So, but some do not have that. So if you can observe that inside the mouth, using that, the distorted occlusal plane can be kind of guessed. So as I said, again, it's not one stat or one thing solves all different indices in standards. All needs to be pulled together to help you get the answers to how to restore the occlusal plane. So there are tools you could use. Now, the tunnel series, this is the occlusal plane that tool can be used, and as a tool on this both sides symmetrically on the central line, the same height, there could be some evenness, and tools can give you. And there could be also a occlusal plane analyzer, a plate. So it's not something you create. It's in the articulator, you make an assessment, and the technicians create based on your assessment. And through such a process, a lot of things can be done if you use the tools. Can I ask you a question? Now here you use occlusal plane analyzer, and this occlusal plane analyzer, be it natural teeth or full denture, can you use them for both cases? Yes. I just talked about occlusal plane analyzer, and that is very much articular focus, and it can be if it's used by pen, you can use it. But if you exist as just tool, then even on the mock-up model, there are landmarks, so it's very easy to use. Now, then, on the live chat, let's answer some questions. Now, I've been waiting for this lecture series, and I look for today's lecture. It says Endo Kim as ID, so he's probably doing endo a lot. Thank you for that encouraging comment. And also, good to see this series again. And Professor Park Chan-ji, nice to see you. Hope you will do a lot of lectures. I think he must be your fan. And then we have a question. Then tweet 69 asked, increasing the occlusal plan, the articulator, how much function does it have? Semi-adjustable articulator, is that a must? Well, basically, now I do understand why you are asking that. It should be same as your head size. So even semi-adjustables or average movement articulators have the head size. I mean, head size sounds strange, but head size articulator is sufficient because adjustment you have to do orally anyways. So WhatsApp or creating prosthesis will be all okay. So for full mouth rehabilitation, articulator needs to have a very good functions. That is our preconceived notion. But you are saying that if it's semi-adjustable one, then it's more than sufficient? Yes. I hope that answered the question. Thank you for that question. And then with 69th, thank you for that question, and we'll send you the coffee coupon. And also others who have given a lot of good encouraging comment, thank you very much. Again, if you have any questions or comment, please post them. We'll try to answer them as much as possible. Please continue. Yes, thank you very much. Now, in the occlusal plane, the summary will be evaluation. Use your school knowledge you have learned from school, and kind of unique occlusal plane. It's more like a mechanical knowledge you need to consider. But the base of assessment needs to come from various sources, multiple indexes, standards, etc. But symmetrical is very important because it's important in terms of function. Being symmetrical is key. And on the posterior side, what you need to be mindful is that, something that some people do not think much about, the occlusal plane becomes lower on the back side. If for full mouth rehabilitation could result in porcelain fractures. Now, if you're 6 and 7 missing, then you leave that be and then think about occlusal plane. I can understand that because you have to remove implant and create new. So you just let what is already there be. So if the VD is increased, then on the posterior it goes a bit lower. Then on the posterior side, you have to always adjust. Otherwise, you have a lot of porcelain fractures. So if you see the bottom image, you have all the fractures, and on the posterior there's implant, so you have to be watching out for that. Now let's talk about the VD now, and this might be a tricky area, so I've tried to keep it simple as much as possible. This is a case, and if you see, rehabilitation looks very challenging using removable or fixed. It's also tricky, and after there's a loss, there was no restoration for a long time, and there's also wear of other teeth, so extrusion might be inevitable. So there are indices you can use for making decisions. So you have the methods for evaluation column, and you see whether there is a posterior support, and so a way for making evaluation and what is normal or not, rather than looking looking at from that perspective, what I would like to say, aesthetics things, VD, how much needs to be aesthetically, and secondly, the VD needs to be comfortable for the patient. If you focus on the two, it will be good. So how much of the increase, the minimum might be good, but in terms of rehabilitation or long term, minimum might not be good because of the wear. So being sufficient might be better. So if you have that range mindful, then aesthetical support, and so again, posterior support is important, and plus patient being comfortable with it is also key. So depending on scholars, there are different criteria. There's no one right answer. The clinician makes determination based on his or her preference. So on the right side, these are some of the ranges that you could be taking as a reference. So what I would like to say is this is like Turner and Massilian's article. The categories is for easy reference. And what is important is that for full mouth rehabilitation, what is loss on the posterior is important, and that determines whether implant can be effective and whether it's a space for rehabilitation. What is important is if there's for rehabilitation patient, as the occlusion is collapsed, they don't come immediately. Some come kind of late, and there's a lot of wear, so you have to be considerate of that. And as you can see, there's a loss on the posterior side, and you see a lot of wear here. So there's a excessive wear happening very quickly, and VD needs to be recovered. So because and you have to think about the space, whether it's available. So, category here is not important. There's loss on the posterior, and then you have to increase VD. Then mechanically, the muscles has been already compliant. That means a long-term temporization, and you have to monitor. Rather than such a mechanical approach, be more flexible. After loss, what is happening in terms of wear, if it happens very quickly, excessively, then you don't have to wait a lot. There's a quick compliance. So sorting these cases out would make the case less challenging. But the key, more challenging case will be number 2 and 3 cases. So there's a bit of wear for number 2 category, but there is a limited space available. Then aesthetics-wise, if it's okay, then using the current VD will be okay, or slight increase of VD will do. On the aesthetic zone, if there's a demand, then slight increase would do. So again, from the VD side, maintain. But aesthetically, in the criteria I talked about, on the anterior height, it might be lower. But anyway, restoration would be possible. So for number 1 and number 2 is a bit tricky than number 1, but patient's compliance is still easy. But for number 3 category, so there's teeth, but a lot of wear, for long-term wear. So here, you have to a lot of VD increase, otherwise you will not get rehabilitation. So you need sufficient VD increase. So on the articulator, you make an evaluation and make a decision. And you also need a lot of long-term temporization period. So you have to monitor the patient, whether the patient becomes compliant, and with the temporization, as it needs to be lengthy temporization, it's going to be tricky. But time factor is important, because category 1, 2, 3 are not, like really black and white. They come very simple case, but they came too late, so requiring full mouth rehabilitation. So it's a mixture of different categories for patients. So you have to watch the patient conditions carefully. So another case, if you do evaluation, there are different evaluation steps. And based on that, again, temporization is a must. If you are not sure, then the increase based on the articulator roughly you, of course, at the later stage, VRCR will be done again, but provisionalization, temporization needs to be there and needs to be sufficient. Then that would make things a lot easier. So in terms of rehabilitation, if there's a sufficient full restoration is key. And I said before, aesthetically, consideration needs to be made, and whether it has a comfort for the patient is also key. Yes, clinically securing VD and setting the occlusal plane is important. So in terms of order, what needs to come first? Ultimately, oral evaluation and articulation, you need to go back and forth. But I think VD needs to be determined first and then go to the occlusal plane. Because occlusal plane is division of the maxilla and mandibular, and there's kind of the inclination on the anterior posterior. So occlusal plane needs to be considered in that way. Well, you talked about occlusal plane and then VD, so I was wondering which came first. Yes, occlusal plane is what we learned from school, and that's why I talked about it first. Yes, but clinically you are saying VD needs to be determined first and then secondly occlusal plane. Yes, that's the way in terms of steps to go in clinically, VD and occlusal plane. Well, let me continue. It's about the centric relation record, or what we call CR record. And using tools is very useful, and anterior jig or leaf gauge is what you use. But here you need maxillar anterior in existence, and if you have anterior teeth, using these tools will be very useful. Now leaf gauge, I don't think many people would have that. For anterior jig, if you know the concept, it can be easily created. So as you can see, you do kind of wax up and you create to cover some upper teeth, and you can let the technician create it. And number 1 and 2 premolars, if that is 1 or 2 millimeter gaps, that's sufficient. And if you have such sort of anterior and lateral movement, there is a cross line that comes into contact, and that gap is recorded. So you put something like that pink, and then on the posterior side, the master muscle comes into contact, and from the spade, the TMJ goes to the anterior superior location. In other words, what is important is not to make it too thick. So using the space, you check the bite. And if you have the anterior teeth, using these tools are useful. But the leaf gauge, it's very thin. You sort of stack up the 50 thin slides or layers, so it should not come into contact, but still it should be thin enough. But if it's too thin, then it's flexible, and patient can bite on it. Then you have to make it thicker. So leaf gauge wise, for the deep bite, in other words, it's not very useful. So you can use a tracer. It has its own benefits, and using this type of tools is something you need to get comfortable with. But once you get comfortable with, it's really good. But what is more important is this one. Clinically, practitioner, how you guide the patient. For full mouth rehabilitation patient, how you can be consistent is very important. As I said, consistency is key. So chin point guidance or the chin point guidance with anterior jig or the bilateral manipulation is all things you need to think about. So there are different, points you can take into reference. What I mean is there's no one golden rule. There's no one right answer. It's more about for the practitioner, for the same patient, guiding the same consistent positions is more important. So for chin point guidance, it looks very simple, but to the patient, so the head position and hand position is important, and how you close with the thumb is also important. Now, apologies, but again, there is a question about vertical dimension question. So let's answer that. I think from Seosan Duri Clinic, the question came in. So if the teeth are healthy and the wear has been compensated by the protrusion of the alveolar bone, so there's not much loss of VD. So while maintaining VD, restoring with the crown alone, would that stop the overall abrasion or tear or wear? Well, I think I can see what the doctor means. So overall abrasion, stopping that, it would contribute toward that end. Because of the materials properties, the patient, how they do the diet, or he has his own habit. So there could be some material-related wear, but the speed would slow down or stop. And that opportunity can be used also to change the patient diet. So it would contribute. Yes. Thank you. Then I think Duri Clinic and Friday, other people have all made comments. And another person said, please keep the series going. And there's another question here from Kuo. It says, when using anterior zig, if you don't make it correctly, then it can be pushed toward the backside and guiding the bites that way. So in checking the CR, what is the best way for patient to bite? I think yes, question is related to CR. I think it's based on the doctor's experience, and I also have that experience too. So in principle, anatomically, if you take the panorama picture, 3D wise, the space and soft tissue all makes it difficult to make correct determinations. But anterior zig, it should not be convex. It needs to be flat, or it's better to be concave. But the thickness, if it's too thin, then it's not useful. So as I said, mechanically in number 1 and number 2 premolars, securing 1 or 2 millimeter gap is important. But if the occlusal plane curve is too steep because of wear, then 1 or 2 millimeter determination will be difficult. So you need to then consider other things too. The thickness can be adjusted in creating anterior zig. The form should not be, as I said, should not be convex. It should be concave. And the thickness needs to be increased to get you to the right point. So it's not about cutting continuously. You create one and maybe add another material to see what is correct. Another question, if there's a lot of wear, it's really tricky. Yes, that's correct. Yes, it takes a lot of efforts, and there's a lot of different things to be considered. And as was already mentioned, 10 or 15 years ago, the full mouth patient still requires repairs and continuous monitoring. Yes, you need a lot of repairs. That's correct. And the patient economically, if he's well off, it's okay. But full mouth rehabilitation is economically also and financially burdensome. So, but if the patient has a lot of wear, what to do? Yes, it's really tricky situations. Now, Bimateno has a question. You have to get rid of the reason of wear, anterior and posterior, or 1 or 2 millimeters. If it's left, then what to do? Yes, that's tricky situation. Now, you can, have different approaches, but the key here is posterior side is the most important. So if there's no posterior, then implant can help. If there's a posterior side, 1 or 2 millimeters, then you need to increase 3D a lot. So if you have posterior and 1 or 2 millimeters left because of wear, then it's really challenging, tricky case, because with the posterior loss, you have accelerated wear. But if that's not the case, you have the overall wear, everything is short, it's really challenging. The crown length is short. Doing bridge is tricky because you need to do bridge lengthening. Yes, you have to do lengthening, really increase other things. Yes. Okay. If there's a lot of wear, can we use zirconia? Can you talk about materials later or now? I'll do it now. Now, I don't know what to say. Well, let's say it was an experimental. It's because, two conditions I want to talk about. Now, first, if it's full mouth rehabilitation, you always use the gold because of patient's comfort, and because of gold, 3D was increased and gold was used, but the gold has been pushed backwards, and there was perforation. So I think, of course, it's different by patient, but if it's related to implant, if the maxillar posterior side implant to implant contact, then 100% there's intraocular result. So I switched the material and then used metal crown, but metal crown also, with the minimal wear, it really becomes flat and it becomes sharp and edgy. But zirconia, in that regard, zirconia itself has, yes, a bit of wear, but has the least wear of all the materials. That's what the literature says. But in case of full mouth case, whether that is really true clinically, I cannot say with confidence. I'm actually doing such a case now. Secondly, zirconia, apologies, but it's really tricky to use for natural teeth, because zirconia crown, if you open it up, then the cement part. Now, the CAD has really improved and cement space has become really thin. But despite that, resin cement and teeth and zirconia, all relations are disparate. So full mouth, in terms of long-term results, whether we can opt for zirconia material, I cannot say with full confidence. Yes, zirconia, another thing is that the fracture. Zirconia also can fracture, so we have to be really careful. For other questions, maybe I'll ask a bit later. Please continue your lecture. Again, chin point guidance and the bilateral manipulation. Now, for bilateral manipulation, I know some use very diligently, but the most thing to be careful is thumbs are okay, but four fingers, they do not overlap. These four fingers need to be in the angle part, so it not should be broadly distanced. That's meaningless. Master muscle, you have to pull it from behind. So that's a tip. Now, the most important thing is this one. Now, when you do CR record, why you do that? It's because there's no reliable position on the mandibular side. This here, the teeth has been worn a lot, but there's a lot of ugliness or there's protrusion, and so that's really making the situation tricky. And you should do multiple CR recording. If you're doing one, it's because of the clinical environment or patient compliance. But so you have to make patient relax as much as possible. Another ones you shouldn't do as soon as he arrives at the clinic. You have to let the patient be relaxed as much as possible, and the practitioner needs to be consistent. Be always consistent. It's just one bite and looks simple, but just for one step, all other condition needs to be fully controlled because of consistency. That's key. Now, this is temporization, and sectionally full mouth size, the bites always change, and it's how you go to the next step. And in CR record, as I said before, practitioner needs to be training the skill. It looks simple, but it needs to be consistent, always the same for the patient. You just hold it, and you try to control the chin, and bite manipulation needs to have accurate guidance. So this is simple, but needs to be always accurate and consistent. That's key, and that is why you train yourself, and that is how to be considerate of the patient. So how to take CR record? There are different ways. What is the best way for you, or the most preferred way for you? And depending on the case, do you take it differently? Now, if a dentalist patient, chin point guide is the only option, because the limb, there could be not, it can be moving too much. So if using tool is best if you have some teeth on the front side. And for these tools are very effective. But if you don't have anterior teeth, you just use it for the checking purposes, because positioning might be tricky. VD has decreased, and if there's deviation on the mandibular side, then the tracer becomes meaningless. So, again, if it's edentulous or close to edentulous, chin point guidance is what you use. And if you have teeth and there's some teeth on the anterior side, or you can create teeth front and anterior jig, is what you should opt for. Now, another question. Now, from Seosan Duri Clinic. So there is a loss of the posterior support, then implant restoration is what you also need to do. And as a material, PMMA resin looks very attractive. It's easy to use and to respond in occlusal changes. What do you think? So besides using as a temporary, can you also use that as a final? What do you think? PMA resin. Well, as a permanent, I don't have experience, so I cannot really talk about that. But I believe the question was asked because PMA is the densely packed for the cam purposes, right? Yes, hybrid PMA probably. So for evaluation, it could have meanings, whether it's correct or not. I think the question was asked because it's easy to respond to the occlusal changes. So it's very good for evaluation. Yes, using for milling, right? Yes, I don't have much experience, so I don't use that much. And that's what I say that OSSTEM that because of the financial burden, not many patients go for the full mouth rehabilitation. So what do you do? then I go for removable because it's inevitable. Yes, I want to do full mouth rehabilitation, but if the patient doesn't have the means, then it's inevitable. Now, for a hybrid, where there's teeth loss and you place implant, then the cost goes up a bit. So patients very compliant to the evaluation stage, but then stop coming. So, and they sometimes offer denture. And if they go for denture, then implant is used only in few for support purposes as a IARPD, and that's how I suggest as alternative. So again, if financial it's a burden, then you have to meet the patient's requirement, but it's really tricky. Yes, please continue your lecture. Now, so through that, you do treatment planning. Let's look at one case and finish my lecture. As I said before, diagnostic phase is the most important phase. In treatment planning, if you have a lot of experience, it's good. And in diagnosis, if you know much, you can see much better. What I mean is that in the clinical setting, rather than you become experienced, it's more about you have the base and you made it simple for you and you personalize it for yourself. That's the important thing. So I'm putting this slide again because maintenance phase is as important as other phases, because after war, you may have to make sure the war does not happen again. So all phases are important. So this is another case. So overall, there's a lot of wear and there's not much of function and VD on the posterior side. There is a reverse curve of Wilson. So that's what you can see. So this is after everything kind of aligned. And on the anterior mandibular side, so you see there is not much of the support on the posterior side, and after extraction there's a lot of collapse. So with the implant, this becomes a very simple treatment plan, and there's a sectional bridge, and you can have a full mouth maintenance. So that is the strength of the using implant. So that would be the first treatment option. So this is very textbook procedure. VD and occlusal plane is assessed. In case of VD, the occlusal side, rather than looking at the space aesthetically, whether there is a sufficient profile, and in the diagnostics, VD occlusal plane is assessed. In the final restoration, you have to recheck again. So again, you use implant here also. So you create temporaries, and in the temporization period, you do evaluation. And once everything is fixed, here zirconia was used, and it looks okay. But whether it's really okay, you have to see, because as I said in the beginning, I've been using gold, and it's been 15 and 20 years ago, so I know the result. And if you see a lot of articles, they have 20 years of cases also. So zirconia crown or bridge, rather than if it's combined with the natural teeth, how that changes the occlusion and how that needs to be approached is something we just have to see. As I said before, different concepts are needed and standards are needed, but one by one, it's not that difficult to grasp. So if you have your simple protocol in place and stick with it and be consistent, then I do not believe full mouth rehabilitation will be as difficult as you thought. Well, I believe the lectures are almost over. So in case of full mouth rehabilitation, it costs a lot. takes a lot of time also. So if you get started, then of course for the patients and as well as the doctors, I mean, it takes a lot of investment in terms of time and other things. So you have to do treatment well, but it also patient compliance and patient aftercare is very important also. So in terms of patient education, which is very important, what are things we need to think about? So what are the things patient needs to be educated? Now, as a practitioner, first thing I want to emphasize is that, yes, the margin needs to be correct, the occlusal plane needs to be also adequate, and it needs to be aesthetic. Let's say all this has been solved. Besides that, after setting, occlusal adjustment needs to be not done a lot at the beginning. It should be in short intervals, and patient needs to be recalled many times. So slow by slow. So overall, it requires a few months. 2 or 3 months. So I usually recall the patient every week. And there you don't do a lot of occlusal adjustment. You need to give patient time to adapt and comply. So for practitioner, that's how you get the stability in occlusion. And from the patient perspective, you need to come to the regular recall, and practitioner check, there should be no problem. Superior management is key, and if there is issues or you have to extract tooth, then the designs needs to be restorable, and so overall regular maintenance is very important, in other words. So after doing full mouth case, myself also, when will the patient come back, because there's a trouble. So if there's a trouble, if it's long bridge, you have to take everything out. So going section by section is also important. What do you think? Yes, of course, I agree. Thank you very much. Again, thank you for a very good lecture. And because the good lecture was good, we also had a lot of questions. And we have a few more questions here. Now here, ID with the go. If you have taking the Gothic arch, then you need to have a lot of cases where the VD is low because the practitioner did the work and the patient sensitivity has also been reflected. Would that be okay? I think he's talking based on experience, but what you need to check is there's a inclination from the occlusal plane. The plate has been inclined, so there could be some slides. So you need to check for that. So the VD, when you have measurement, when the mouth is closed, check what that. So in the closing path of the patient, whether it's vertical, needs to be checked. So you need to check that. Besides that, well, the patient sensitivity. So patients prefer actually lower VD than higher VD. Yes, that is correct. So two conditions need to think about. So from Sausanduri Clinic, if the thickness is sufficient, PMMA, would that be better? Would not he posted that? So actually, PMMA as a permanent prosthesis, I didn't use for full mouth cases that much, so I cannot really answer that. What about you, Professor Park? Well, I do believe he's speaking from his experience, and that's why he can be so specific. I believe in case of hybrid ceramic, so when you make a crown, there's a high failure rate. So a lot of companies took that out as an indication. But ultimately, it's because of second caries and loosening and wash issue, because But implant is a different case. So I think that thickness would be meaningful. Yes, it's okay for implant. Okay. And Good Day asked overall where if the do rehabilitation when or there's so if there's overall wear and occlusion has been collapsed for full rehabilitation, when do you determine to use implant and where to put the implant? If there is a loss and you place implant and look it on the mock-up, that is not the way to go. Like overall, you have the overall blueprint of where you want to do as an end goal, and then you determine the implant position, and then you determine whether to go with the bridge or other things. So you get the overall end picture in mind, and then you do approach 6-month section. And then another case is if overall wear and the implant restoration, what needs to be considered. I talked about 5 principles: stable start, disclusion, and also there should be no interference. These are things you need to think about, these 5 principles. But in terms of wear, I think materials needs to be also considered. And then Dr. Bae Jung-in said, in guiding CR, would I be able to have one day be comfortable in doing CR? I think he thinks CR is very tricky and challenging. What do you think? It's not easy to be confident about your CR. I think indirectly I can answer with my own recent experience. So there's a old lady, and it's been using the rehabilitation quite okay, and I thought CR recording was good, clinical remounting was that good, also occlusal adjustment was good, and there's alignment also done will go good, but she didn't came a lot after that, but there was a contact and wear, so after a time. So what I'm trying to say is that the CR positioning, don't be stressed or insist on that. So it's going to change. Prosthesis CR is going to be changed on the prosthesis. The criteria will, the setting will change. So you just find the comfortable position at one point in time. So there is a CR textbook and clinical CR. So the textbook and CR is different from the clinical CR. Yes, there is a gap. Yes, that's what I wanted to say. Good Doctor says, thank you for very nice lecture, Professor Park. Yes, thank you. Now, with that, thank you for a lot of good posts, and thank you for all the questions. And to those that have asked questions, we will send you Starbucks coffee coupon. And our live chatting event continues. We have prosthesis on Friday every 2 weeks, and we will have chatting box in use every time. So we look forward to your continued participation. Thank you very much for a very nice lecture today. And before you go, anything you want to say in terms of where to your seniors or your colleagues or well, not to my colleagues or seniors, but to my juniors. I just want to say words of encouragement. There's a lot of advancement in machines. There's all different things to learn. Yes, now it's everything digitalized. Yes, all the advancement is good and helpful, but as one person, as one dentist, you don't need to know everything. Rather than that, your knowledge and the skills needs to be trained repetitively. That's more better for patient. So I'm not saying repeat what you have done, but the skills that you are using now needs to be simplified and personalized. But of course, it needs to have scientific base. So if it's scientific, has a scientific base, then train repetitively so it becomes personalized. So, scientific based approach and train what you think is best way for you so that the knowledge can be transferred to your hands and be helpful to the patient, right? Yes. Again, thank you coming all the way from Gangneung to deliver this lecture. And there were a lot of questions, and that's why we went beyond the allotted time. So thank you for staying until the end. Thank you, viewers. I hope this first lecture of 2022 has been helpful to you. With the new year, we created kind of new set. So we'll do our best to deliver good series of lectures to you for this year too. So we look for your continuing support. I hope today's lecture has been helpful to you. And if you have your question not answered, we will answer them in the comment chat box. And in the next lecture, the second Friday lecture, we are going to using implant and general prosthesis for restoration of patients with abrasion or wear. Thank you for joining us and being with us until the end. Thank you very much.
감사합니다.